Welcome to the worst snowstorm Toronto's ever seen. I don't know what it is, but sometimes all you have to do is say the word snow and it goes crazy. But it sounds like there's a very good chance that a lot of people chose today to be a snow day because of everything that was predicted to happen. And so traffic wasn't too bad and commutes were a little better than normal. So maybe it's a good thing in the end on a Friday, not sure. You're probably wondering, because I always told you what day it was when we were going through Cohort 13, so you're probably really curious about what today is, but there's only one important thing about what today is, and today is Cohort 13's graduation day. Nothing else matters, so I didn't even Google it. But we'll say this a number of times today, and the teams that I have the privilege of working with are tired of hearing this. Today is just a date on the calendar. It is not the end. It is not goodbye. It is none of those words. It's a date on the calendar where you are going to share with us the great progress that you've made and what you're really excited about in the next stages of your project. So remember our Hotel California analogy. You might think you're checking out today, but you can never leave. And we'll talk a little bit about that at the end of today as well. I will do the setup for your presentations after we have our opening remarks, but just as you're thinking about it in particular for the first group that's coming up, very similar to what you experienced in Learning Session 2, so no worries, no stress. We're really excited that you're here to share your stories with us and really excited to hear about your progress. So, take a deep breath, have an extra coffee, enjoy the bagels, and it's all good. But to start us off this morning, we do have some opening remarks. And so I wanted to introduce you to, I'm going to introduce both of our opening remark speakers at once. I know that they know each other really well and have done many of these presentations, I suspect, back to back. So we're really privileged this morning to have Ross Baker here. Many of you know Ross. Ross is the co-principal investigator for ideas. He created this. Can I say this is your baby, Ross? Can I say? Sure, I already did, so now it's too late. Yeah. He's the professor and program lead for quality improvement and patient safety here at the University of Toronto in the Institute of Health, Policy, Management and Evaluation. He also is the co-investigator on the Canadian Adverse Events Study and led a 2009 study on effective governance in quality and patient safety, resulting in the Governance Toolkit. His recent research is on patient engagement. He's had several awards, the Health Services Research Advancement Award, Fellowship in Health Admin, Canadian Academy of Health Sciences, Ted Friedman Award, Peggy Elite Award, and Impact Award, and the Bearer Flood Prize in Health Services and Policy Research. So we're really thrilled that Ross can be here this morning. Ross is joined by Vanessa Perry. Vanessa is standing in for Frederica, who you'll see on your agenda this morning, but we're really thrilled that Vanessa's here. She's come to talk to a few of our graduation days. She is the manager and HQO liaison and program development for the Ministry of Health and Long-Term Care. And I want to say that that is in a division called Quality and Funding Division. And I think if I aspire to anything, I want a title that has funding in it. Don't you want to have a title that has funding in it? So I aspire to that, Vanessa. So I think Vanessa's going to start us off, and then we'll hear from Ross, and then we'll have some time for a little Q&A. We're really thrilled to have both of these folks here, and they're interested to hear from you. So as you're listening to them, sort of be thinking about what are you curious about? What would you like to ask them after their presentation? So all good. So Vanessa, welcome to the stage.
Long walk up at the Oscars, go around the room. Good morning, everyone, and thank you for having me here today. I'm really thrilled to be here for an ideas graduation. I was saying to somebody the other day, in the ministry we go on with our work day after day, and coming to these events gives us a certain energy to hear about all the amazing work that's happening and all the projects you're working on. And thank you to the ideas team for putting on such a great graduation. I'm always very impressed. These events are designed to celebrate the exceptional work that you've taken on, and in particular for your cohort. And I want to thank you for your dedication to and commitment to quality improvement across the province, and recognize what impactful projects you've undertaken. I really enjoyed reading through the summary of them, and look forward to the presentations. The time and effort that you put into this work is really remarkable, and is such a commitment to the delivery of high quality care to Ontarians all over the province. And individually, your work on this and your commitment to this is setting you up as leaders for quality improvement in the system. You're really going to come out of this project and really go forth and hopefully be leaders in your organizations, in your communities, to ensure that we're continually looking to improve the quality of care we're delivering. And you're also really lucky to be joining a network of other ideas, alumni who have previously gone through this program, and will create a network for you to draw on. One thing that I really love about the work that you're doing and about this cohort is that you're basing it around a quality standard. And around a quality standard on mental health in particular. The transformation of the system that the ministry is undertaking right now with all our partners across the system through Patients First, when it was developed, the creation of a quality standards program and setting it up as not just the creation of quality standards, but really trying to understand how we implement quality standards, how we make standards real, was a key pillar for that work. And the work you're doing and the projects you're doing today are at the forefront of us figuring it out. You know, we're still early on in bringing quality standards out into the province and understanding what it takes to make them implemented in a sustainable way, how we spread them across the province, how we make people aware of them, and how we support their adoption. So your projects are representative of how we make this tangible, how we and clinicians and healthcare organizations can work together to improve equity, consistency, and care. And when I look at, in particular, the major depression quality standard, and I look at your projects, it's reinforcing such an important shift in the approach to mental health and depression treatment that's grounded in interprofessional collaboration, shared care with patients and caregivers, evidence-based, a strong, approach that's based on the best evidence, and that it's consistent and addresses the entire spectrum of need for the patients and clients that we're dealing with. These standards, it's a challenging task. There's a lot in them, but I think what you've done is the really challenging work of taking evidence and translating it into clinical change. So I applaud you and really look forward to hearing what you've accomplished. As we celebrate this, and as I mentioned, you're going to go forth into the world and you're going to be quality standard leaders, and it's going to be challenging. We work in an extremely complex system, but I hope that events like today really help you realize the importance of what you do and galvanize your work, and encourage you as you continue. So again, thank you for your work. Thank you for being here. I want to, on behalf of the ministry, say we really appreciate everything that you're doing and applaud what you've accomplished and will continue to accomplish. And really, I'm looking forward to hearing your presentations. So thank you.
Okay, so welcome everybody. Did you think it was going to come this quickly? Right? It's great to see you all here and to hear about the projects that you've been engaged in, and we're going to hear more details about that, and I'm really excited about this. As you've already been told, and you'll be told again and again, this is not the end of the journey. This is just an important step in furthering your learning and furthering an understanding for Ontario and for the patients and clients that you serve, so that we can build a system that provides the best possible depression care in this system. This is the first cohort that really is explicitly linked to a quality standard. It's not the last one, because we think this is a really important strategy to take this work that's been done to really summarize the evidence about what excellent care is like, and then to link that to a series of tools that allow us to change the daily practice, the collaboration and communication between clinicians and others in our system to involve patients to understand how to do this in a meaningful way. So our goals here were really to test this out. PDSA, right? You are a big PDSA cycle on our strategy to improve the implementation of quality standards. And chatting with coaches and others, and looking forward to your presentations today. I have to say, we have some very positive feedback on this idea that quality improvement provides an engine to turn the work of the quality standards that we've developed in this province into daily practice. And you are the early adopter teams. You're the ones who show what's working and what isn't working. What are the challenges? What are the barriers, right? You have to be there looking at it, understanding it, in order to really see it clearly. And so part of what you're going to do today is give us a sense of, you know, where is this tough? Where do we really need to be thinking more about what we're going to do to make a difference here? What are the key ideas that seem to be working, and where do we need to continue to refine those ideas? And those relationships. So one of the benefits that many teams have had is this creation of new relationships with others caring for the same clients in the community or in the hospital, right, who now understand each other's mission better and understand a bit more about how to work together. And I think that's really important. So you're our wonderful experiment in understanding how to do this work and to create a basis that we can expand moving forward. The PDSA cycles that you've been doing really help to illustrate how to take the big standard that exists at a high level and translate that into small changes within a local environment. And that's really critical. You know, people who haven't done quality improvement don't understand how tough this is, right? I would recommend any senior leader who really wants to understand what this is all about is to spend some time with a few quality improvement teams and really get a frontline view of this. Because as you know, even things that seem relatively straightforward, obvious, simple, are challenging because we're asking people to change what they do on a daily basis. We're asking them to change who they work with, how they assess what their practice is on a daily basis, and that's very changing. And you know what? It's not an easy time. People are feeling very stressed. I don't know any of you had this reaction where you go and ask some of your colleagues to say, we're working on this quality improvement project and we want to involve you, and they look at you like, you don't think I have enough to do? Please go away, right? So part of this is understanding not only the technical side of this change, but understanding how to engage people. And I have to say that is a challenge, but there's some good news here. The good news is that in this very stressed time in our system, quality improvement offers an antidote to the pressures and the sense that we can't do anything to make our life better. It gives you hope. And I see this every year with our master's students who come out of the University of Toronto Quality Improvement Patient Safety Masters. They come in energized because they think they're going to learn new stuff, and of course they do. But the thing that they really take away from this is a sense that I now have become an agent in the system who can help to shape the way in which the system works. Give me some opportunity to help change that. And I think that's really important, because there's nothing worse than feeling a victim of the systems that we work in. And nothing better than to feel, oh gee, now I have some tools, some ideas, and some linkage to ways that could make life better. But as we've said several times already, this is not the end. This is a sailing metaphor, and this is not what it looks like today on Lake Ontario, but it will someday soon. And so we are here recognizing that this is just early stages. You've done the first few PDSA cycles. You've learned something about the systems in which you work that help to translate into ideas that may shift those systems forward bit by bit. And so we want to continue to support you, to help you, and to give you the sense that there's a horizon out there that you continue to work for. So I'm going to say a little bit about 7 keys to sustaining and spreading improvement, and this builds on and links to some of the work you've already done in this area, but it's really tied to this point in your journey through this improvement work. So part of this is around measurement and the value of measurement, both in terms of assessing where you are, but also giving a sense of where you need to go, and engaging and linking with others in your work. Engaging leadership. Leadership turns out to be very important in this, and don't be isolated from the leaders in your system. Be one of those people who continually updates people about the nature of your project, that takes advantage of the fact that you're on the elevator with somebody who's in a leadership role, and you give them that 20-second elevator speech about what you're learning about care for patients with depression in your system. Remember that the more you link to priorities and the more you link to the dominant culture in the organizations you work with, the more successful you will be. Think about not only the benefits for patients and the benefits for the system, but the benefits for staff. Assess and secure resources. Engage staff. Build their capability. Find ways to bring them in, even in small doses, and focus on this idea of local adaptation. There is no one recipe to what needs to happen, and you need to adapt it to the local situations. So what I'm going to do is just run through these very briefly with some examples from one of the early cohorts in ideas, just to give you a sense of this. So measurement. You've all been deeply immersed in the challenges and opportunities that come from measurement. It's basic measurement. It's measurement that speaks to your colleagues at home, that creates an opportunity for a dialogue and a conversation, both with your clinical colleagues and with the leaders in your organization. And this is an example from a team that was working on coordinated care plans. And as you know, the ministry in HealthLinks has put a lot of effort into funding and organizing HealthLinks to deliver care to complex patients, and the core of that is around the coordinated care plan that are developed for these complex patients. That's not always easy to do, right? And it requires a link between the family physician, the home care person, that was CCAC when this project was done, right, and the patient. And so this group from Sunnybrook was focused on creating coordinated care plans. And as you can see, this graph isn't always headed in the right direction. But they drilled down on this and tried to find, what are the logistical issues? How do we actually make a difference here? Is it around the patient and how we find and organize the patient to be in these meetings? Is it around the family practitioner, the family doc? And the reasons why these case conferences are difficult to have give us some ideas and remedies to create these conferences moving forward. So measurement is a diagnostic, as you know. Measurement is also a way to tell people where you're making progress and where you need to spend more time. Leadership. And I've already said this, leadership at all levels. So the people who are champions, some of you are champions in your own units. You have an idea of what you want to accomplish. You're trying to engage staff. You're trying to energize them, be part of this project. But there are other champions that you need to reach out to within your units or across your organizations. And then you have executive sponsors and senior leaders who, as I said, need to be kept up. So just because you're finishing the Ideas program today in a formal sense, you're not finishing this opportunity to take these skills and tools and projects and push them to the next level. And leaders are your core avenue to help do that. So remember, if you need additional resources, if you have an idea that's not possible for you to do within the context of your own unit, find an opportunity to have a conversation. You may not always get what you want, but you always keep this on the radar screen. And depending on where you work, the priorities are maybe different. So how do you link your project to the priorities of your organization or the organizations that are working together for these patients? And you have, the good news is that because you're working on a quality standard, there is a high level of visibility around these kinds of issues. So you're already in that sort of frame there. This is a project that was done by Toronto East General Hospital, looking at trying to do assessments on patients who were at risk of deteriorating, identify them early so the interventions could be done there. This is a hot button issue in hospitals, right? Because we recognize that many patients who go into deterioration never recover. And so it's a big safety and quality of care issue. And Chris Hayes has done this great work, and another publication from this work has just appeared in the last month in a journal. This idea that if you want to make change, it's not just around serving patients, it's also around thinking about workload and thinking about the stress and strain that frontline staff have on a daily basis. Can we identify new ideas, new ways to do our work that reduce the workload or keep the workload the same? And if we can do that, then we're more likely to succeed. And part of that is sometimes making a business case for why you might need some additional resources. So this SBC chart, control chart, comes from a team at Markham Stouffville Hospital that was working on discharges by 11 a.m. Now, in places that are bursting at the seams, where the connections with other resources in the community aren't always as well developed as they could be, this is a very challenging thing. And if you look at the left side of this control chart, you can see they work for some period of time to try to make a difference. And that control chart just bounced up and down around the median saying, nope, not making a difference, not making a difference. So finally they went to their senior leadership and they said, you say this is a strategic priority for the organization. You think you can save money, you can think we can use our resources more effectively by getting these patients more reliably out of the beds by 11 a.m. And they said, yeah, that's right. Well, we're trying as hard as we can, and we can't do this because we don't actually have enough people to put this together, right? We need you to dedicate, and we could do it on a trial basis, a nurse practitioner during the key hours to help make sure that this happens. And look what happened when they did that. Look at the right side of the chart, right? So sometimes strategic investments make a difference. And so you shouldn't feel a victim of the current system that you're working in. You should feel an opportunity to help to change that system, making a business case, thinking about the resources and the opportunities to make a difference. Another example, smaller scale from London Health Sciences Centre, they were doing a project on patients within the hospital trying to reduce deterioration for these patients who were in hospital for a period of time. And they did a variety, look at all these PDSA cycles, a variety of PDSA cycles around staff, conferencing, verbal reporting, post-it note tracking, et cetera, PT assessments, right, all these things. But they ran into a problem, which was that they were trying to engage the nurses to mobilize patients regularly, right? But the nurses looked at them and said, well, you know what, love to do that, but there's only 2 walkers on the unit, and they're always at the other end of the unit. And if I have 5 minutes with a patient, I don't have time to go and find the walker, bring it back, and mobilize the patient. How much does a walker cost, right? Not very much, right? So they went to their administration. They said, we need more equipment. And we need to put the equipment in more places on the unit so it's more visibly available. And if we do that, we think we can make a difference. And they did. So, and engaging staff, building capability. I love this example. This is a group from St. Paul's Lamoureux, a day hospital. Budgets for day hospitals are pretty limited, right? So when they did quality improvement on a shoestring, right? But this was a very enthusiastic group that had real champions within it. And they said, we're going to involve as many staff as we could. And I think initially some people thought, these guys, need to get a dose of reality, right? If they can do their project, that'd be great. But they were very, very engaged in this. And so they built information, they had staff meetings, they shared everything they learned here with their staff. They went home, shared the materials, taught them, and they did this great job of bringing other people into the project. So I always think, if they can do it with the resources that they have, what excuse do the rest of us have? So, and then finally, this question about local adaptation. So we do have some sense of what best practice looks like, and that's why we're developing standards and other materials. But those standards don't come with detailed implementation manuals. And part of that is that different settings have different challenges. They have different resources, but they need to think about that standard at a local level. Quality improvement is an important tool to help make that translation, to talk about the small changes you need to do within your units in connecting with other people who are providing care to the same colleagues or same patients that you're dealing with. And we want to end up with some sense of standardization. That's what we call it a standard. It's saying, here's what good care looks like. It should be here the same everywhere. But it's how do we customize the local care in order to meet that broader standard, right? There isn't one size fits all. Depends, are you in an inner city environment? Are you in a rural environment? Who are your partners? What strengths do they have? What challenges do they have? How do we build a set of communication and tools to overcome that? So quality improvement is, I think, a road forward in this. It does offer hope. The voice and experience of patients provides us with additional insights that help us to design things that are going to work at a local basis and to make the changes that will help us all. So again, going back to the coordinated care plan example from Sunnybrook that I started with, they spent a lot of time talking to their patients because one of their big issues was engaging the patients in a meaningful way. So 7 things. These will be available for you to look at after the session today. And I have to say, there are other resources out there available for you. Every year and every October, there's an alumni event that's sponsored by Health Quality Ontario and the CQIPS group at the university, which really provides important learning and opportunities to really move forward in your own education, your own development around this. So you haven't had Quality 100, that's a sort of foundations course. You've had Quality 200, but there's lots of stuff to do here. And the power of the quality improvement tools increases your ability to use it in an effective way, in a timely way, right? To cut down the time it takes to test out PDSAs is really reinforcing. So I urge you to continue on this path. And there is an Ideas Alumni Community of Practice on Quorum. I urge you to join that. Hear the examples from others. Contribute your own examples moving forward. Ask questions about things that you want some help on. So again, my congratulations to you for coming along with us on this journey. You've joined people across the province and elsewhere who see quality improvement as an important adjunct to the knowledge you have as practitioners, as managers, as members of this healthcare system that's doing good work in tough times. Thank you.
Thank you to both Ross and Vanessa, and we do have a couple of moments for questions. So Laura and Joe have the mics. What are you curious about? This is your chance. What are you curious about? Thank you, Kevin.
Hi, Ross. I guess it's too early to say, but do you think ideas cohorts to support each and every quality guideline will be the norm in the future?
Because Vanessa's here from the ministry, let me just say I can't.
And we did not tell Kevin to ask that question.
We can't speak on behalf of the ministry, but so my personal view is that we need something that translates those standards into local practice, right? They don't implement themselves, right? So here's the challenge. So I think that the standards are a good idea. Let me be very clear about that. But I think it's discouraging for people to see these standards and to recognize that those standards are impossible in the context of the current care delivery environment. I think we have a responsibility to help people reach those standards. That's my personal view. And that means working at a local level, giving the tools and support, and sometimes there was additional resources to make that happen at a local level. And it's not special funding by the ministry alone. It's around convincing leaders at a local level. Yeah, care for patients with depression is a critical issue in our system. What can we do here? We have some ideas. How do we push those ideas forward? Right.
I'd agree with everything that Ross just said. And we're working, the question of ideas for every quality standard, I'll say there's a fast pipeline of standards coming. I get the HQO tracking chart and I look a few years out and I think, oh my God, there's a lot coming. And we're working really closely with HQO to think about adoption, as I mentioned, because one thing when we worked with them to set up the program was there's a lot of standard programs around the world, but there's not one that does the development of standards and the adoption kind of as a one piece, and we really want to move towards that. When we get a standard, we really think about, we work with HQO, they actually submit recommendations for adoptions to the minister, it's in their legislated mandate, and we really ask them to look at the standard and say, what are the systemic barriers to adoption? So for major depression, a good example is access to funded psychotherapy, CBT. So that's a recommendation that came in and something we're working with our mental health program colleagues on, and there have been recent announcements about it. And then we also look and work with HQ about what supports are needed to do that kind of local, on the ground, either organizational or maybe even regional adoption. And ideas is, like, I think this is a demonstration of a tool, and a very important tool. It's probably not the only tool to support adoption, but an important one.
Yeah, and I think that in this particular case, in our experience, I could see that if we have to select which ones require this tool, with this particular instance, we've got a pretty wide open system with requirements for primary care practitioners to be a very important part of that system. How do we engage those folks? And that's becoming more and more important. So maybe in a closed system like a hospital process, maybe not so important. Some from a hospital might argue with that. But certainly in an open, we are just barely scratching the surface engaging primary care in a system change like this.
That's really great input. Thank you.
Anybody else? All right, thank you, folks. I think Vanessa and Ross, you're both here. Ross is here for the day, and Vanessa, I think you're here with us for a while. So please seek these folks out over break and over lunch as well. This is a really good chance to have those dialogues or ask those questions that you've been wondering about. So thank you so much for inspiring us. I always have to watch the double microphone thing here so I don't come across twice. So speaking of inspiration, I wanted to sort of set the stage for today. When we organize these graduation ceremonies, we use a model of inspiration, motivation, and celebration. And so for us, that's what we hope to be able to provide for you today. So you'll hear inspiration and motivation, hopefully be motivated by what you hear from each other. Celebration, there are cupcakes at lunch. I'm looking at Claire. There are cupcakes at lunch. And so please take the time to celebrate. As Ross said, the time has gone very quickly, but you have done a ton of work in a very short period of time with all kinds of things that went on, not the least of which was your regular job and your own life while you were trying to do all this. So take the time to celebrate today and congratulate each other. And hopefully you'll receive those congratulations when you're back home as well. I did want to acknowledge that we do have a number of special guests with us today. We have executive sponsors both in the room and listening to us via live cast as well. So we welcome all those. And remember, leadership was one of Ross's 7 points. So we're very excited about the leadership support that we see both here in the room and those that we know are watching us on the live cast as well. We have other folks here from the Ministry of Health and Long-Term Care, folks from the Canadian Mental Health Association, and other HQO staff here who are really interested in, again, hearing about your experiences and thinking about how does that translate into the day-to-day work that we're trying to do with quality standards, and particularly these standards around major depressive disorder. So lots of support here, both, as I say, on livecast and in the room today. So we're really thankful for those folks being here. And I also want to draw your attention to how we'll close out today, which is Michelle Rossi from HQO will be here, and she wants to continue that dialogue around what Vanessa referred to as making the standards real. And what's your experience been like? As you know, you were the first focused cohort on a quality standard, and we're curious. We want to know, and this is a really good opportunity to pick your brains a little bit. So as you're listening to presentations today, be thinking about that. What do I want to share at the end of the day? What do I think the Ministry and HQO and ISIS needs to hear, and the U of T need to hear about this? What do I want to share with them? So please be thinking about that as we go through today. So let me turn it to today, because I think we're pretty close to being on time. We do, as you saw in Learning Session 2, we do try to stay really close to the agenda. In Learning Session 2, it was about respecting and making sure that everybody got their fair share of time, and that focus continues. But today, we have that little extra piece of the live cast that's going on, and it is live now, so your folks are tuning in. And just as I say that, I also want to let you know that the live cast will be available to you. If you want to share it, you've got folks who couldn't join today, you want to show it to your mom, please do. Somebody wants to show it at your next special occasion, that's fine. You want to gift it to somebody, that's great. Put it on your Facebook. But it will be available in chunks. So what you'll be able to see is basically the morning, so 9:30 to the break to lunch, and then lunch through to the afternoon. And certainly you can watch all of it. It'll all be available, and Claire will assist us with sending out that information afterwards. So the other piece about leadership is to keep them informed. So if they weren't able to be here today, send them the clip, right? Show it to them, put it on your monitors in your waiting rooms, whatever you might like to do. Keep those folks informed, so please use that. Let me talk just a little bit about how that we will go today. And again, it's not foreign to you because it's similar to what you experienced in Learning Session 2. But, along with inspiration, motivation, and celebration, I don't want there to be extra perspiration. So I want to try and settle your minds about what we will experience today. So just like in Learning Session 2, you will come up here. Your presentation will be here. We have our great AV support in the back. So as soon as the words come out of your mouth, your slides are going to appear up there. Don't panic. You're well taken care of. The prompter's here, so you will be able to see your slides there. Plus, you'll see them on the screen as well. So you don't need to look there because it's here and here. We will have a timer, and they will sit somewhere here in the front, I think. And Claire will begin for us today, and then I think Danny might be taking over a little later. You will get 5-minute warning and a 1-minute warning, and then the big STOP, where I will start to become physically much closer to you at that point in time. So if you don't want me to be physically much closer to you, you need to stop. But remember, if you haven't got to your last slide, we can read, put it up really fast, right? And maybe, just maybe, somebody in the room will ask you something that's on that last slide. Maybe, just maybe. I also want to introduce and thank our panelists today. So what is new for you is to have panelists in the room. And so the panelists are here very curious about your projects, very interested in what you're doing. I might even venture to say somewhat perhaps selfishly here to learn more and to understand about what your experience was like. And so you met Ross Baker through his presentation. Ross will be here as a panelist throughout the day. Also want to welcome back Dr. Paul Benassi. You met Paul in Learning Session 1 and Learning Session 2, and Paul's one of our subject matter experts for Cohort 13. And just to remind you, he's a forensic psychiatrist at the Center for Addiction and Mental Health. He has additional responsibilities in quality improvement work, completed his medical degree at McMaster, psychiatry residency at the University of Toronto, and he is a graduate of the Masters in Quality Improvement and Patient Safety from the University of Toronto as well. And he is assistant professor in the Department of Psychiatry here at IHPME and supervises medical residents and the master's students. So lots of QI background. And we also want to welcome Michael Dunn. Michael's the Director of Quality Improvement for the Canadian Mental Health Association. Some of you know Michael through his involvement with the EQUIPS program. He's worked in mental health and addictions for over 13 years, lots of different roles from psychiatric outreach and addictions counseling to research and leadership positions. He has an education in psychology, law, quality improvement, and patient safety. Again, the master's program here. He's the Director of Quality Improvement and co-leading the Excellence Through Quality Improvement Act since its inception. Passionate about ethical application of QI as a means to strengthen the relationship we have with clients and families. So a really well-rounded panel today. So once you finish your 10 minutes today, we turn to the panel and we say, what are you curious about? And I hope that your advisors, I'm sure, have all shared the message with you. It is pure curiosity. There are no knowledge questions. We will not ask you what the S in PDSA stands for. There are no knowledge questions, okay? It's well, we might, but you know that one. And so, feel free. If they ask you a question, you're like, no, we tried that and it didn't work. Tell them that. They're curious about that, right? Or no, we didn't think about going there. Thanks for the idea. And then if there's time, we'll open it up to the group again, but we will time again that presentation piece just to be sure everybody gets their fair share as well. But you can certainly seek each other out at breaks. You have connection on quorum and lots of opportunity to share and ask questions afterwards as well if you have more. I think that's about it. And so that should take us right to 9:30. So I want to welcome up Shauna, Bob, and Valerie, Timely Assessment for Depression using the PHQ-9. And thank you for going first. They get an extra round of applause because they're first. What I did forget to mention, thank you, Claire, what I did forget to mention is that once your Q&A part is over, you'll move over to did we decide to go over here? Yeah. You'll move over to my left, and either Laura or Jacob you'll receive your certificates, very important, and then Laura or Jacob will take a team photo today, which you'll also get a copy of. As that's happening, the next team comes up and we roll through the day. So welcome. Yeah. I don't have the clicker. It should be there. Is it not? Yeah. Uh-oh.
That's okay. I'll just use zeros. I'll just use zeros.
It's probably going to run out here in just... Here it comes. There it is. Let's have a round of applause for our AV support, by the way. These guys are great. Just in time delivery of the clicker.
I'm probably just going to use this anyways, so that's all good.
Decide to right is forward.
Okay, thank you. Morning, everyone. I'm going to have to wear my eyeglasses as I have notes in my hand. I didn't know. I thought they might be on the screen. So I'll start by introducing our team. So we have Shauna Belcher is with Aurelia Soldiers Memorial Hospital. Bob Fair is with the Canadian Mental Health Association, and I'm the program lead for the Berrien Community Family Health Team Wellness Counseling Program. And I'd also like to welcome one of our executive sponsors, Philip Huff, who is a director with Aurelia Soldiers Memorial. So really appreciate you joining us today. Thank you. So let's begin. So our client profile, so we looked at our pilot, or our project basically looks at serving individuals 18 years and older who are referred to my program, the Family Health Team program. They may be referred for counseling, they may be referred for psychiatric consultation or a psychoeducational group, or a combination of those things. Presenting issue, we're looking at depressed mood. We have a dual referral process within the program, so that means that the provider, which could be a physician resident, a nurse practitioner, or another healthcare professional, makes a referral through our EMR, so we have an e-referral process, and then the patient also leaves the provider office with a referral in hand. They contact our office to initiate that first connect. First appointment is booked, where we do an assessment to determine kind of next steps. Our project looks specifically at the PHQ-9 and the use of that tool upon referral. And then the next steps, and I'll speak to that a little bit, in our project is looking at the actual scores of the PHQ-9 to inform treatment moving forward. So our aim statement is that by March 31st, 2018, 70% of individuals 18 and older will come to our program, the Family Health Team program, with a completed PHQ-9. And we identified a pilot group through the Family Medicine Teaching Unit, which is through the University of Toronto and RVH. So our provider pool is 25 individual providers that include the faculty or physician supervisors at the teaching unit, as well as physician residents and nurse practitioners. We looked at the first quality standard, which really looked at comprehensive assessment and the use of a validated tool to look at the severity of symptoms. So that's what we teased that out, and we identified one aspect of the comprehensive assessment, which was the use of the PHQ-9. So the changes that we implemented, so again, I identified, we looked at this pilot group, and we wanted them to include PHQ-9s with all referrals that came to our program. We tried to make the change a bit easier for providers to implement, so we included a
tick box for the PHQ-9 on our e-referral form, and we also attached the PHQ-9 directly to the referral. So they didn't have to go digging in the EMR to find it and complete that. We did some data collection so we could establish a baseline around all of the referrals that were coming into the clinic from every provider, a big pool of providers, to look at what was actually happening. So I'll show you some data on that. And we also then started to track, when we started the pilot in January, we started to track all of the new referrals from the teaching unit that came with a completed PHQ-9. So our theory was that the results of the PHQ-9 could inform treatment interventions and improve access, and looking really at the severity. So we haven't yet gotten to the stage where we can prove our theory, because essentially what we've done, our first change piece is a process change, and our next step will be really looking at how we're improving quality. So our lessons learned, so we were fortunate in that we already had a really well-established relationship over a number of years with the Family Medicine Teaching Unit. So I've been able to connect with faculty of the teaching unit through my membership on the Education Committee. My team of therapists provide academic learning sessions around counseling skills to the residents and have done that for a number of years. As well, we run a mental health clinic, a bi-weekly clinic where therapists go in and actually work with the physician residents, supervise them during their counseling sessions with patients. So we had that well-established relationship already. We had a strong commitment from the faculty or the physician supervisors at the teaching unit, so that was really key. And we know that the PHQ-9 is a widely used, it's validated, evidence-based assessment tool, and it's also readily available. So it's in our EMR already, it's been in there for a number of years. Some physicians routinely use it, so we had that as a positive as well. Some of the challenges, we had difficulty being 3 agencies determining the scope, so it took some time for us to kind of narrow it down. But we were fortunate in that we had community represented, we had primary care represented, and we had hospital representation. Provider engagement was another issue, and will continue to likely be when you think about a variation in who's interested in mental health, who's keen, who's not, that kind of thing, as well as some resistance and adherence. So we had to look at how to make ease of use part of this, right? And moving forward, the value in the changes that we're making. So our first chart, we looked at, this is our baseline data. So we used a P chart to classify our data. And our project started in January, so we've only had 2 months of data. So up until December, you can see kind of what our averages are, which was about 14% of referrals came with a completed PHQ-9. And even after our pilot, even though this is our whole clinic pool of providers, we still see some change, some increase in the use of the PHQ-9. This is our pilot group specifically, looking at some baseline data up to December, and then seeing a significant increase from about, so originally 9 to 10% of our referrals were coming with a completed PHQ-9, and after our change, we saw an increase to 42%, and we hope to continue to increase that. So what we're hoping to achieve is that this approach, the standardized approach, the use of the PHQ-9 will really inform treatment for individuals coming into our clinic. It will inform program planning, ensure continuity of care, and essentially our future state really is yet to be determined, because we have to start to look at how we're going to use the scores of the PHQ-9 to determine urgency and then next steps around care. Next steps to improvement, so we want to be able to sustain the process change at the teaching unit. And part of that is through, continuing to engage, get feedback or input from the residents, the physicians, the nurse practitioners, all the providers that are making referrals, and really to continue to stress the importance of the use of a tool that can really guide service or treatment interventions. Expanding it obviously to all providers. So right now we're working with a pilot pool of 25 providers. We'll add an additional 87 providers, so it's a big group of providers. And we want to be able to, kind of the next phase of our project will be to triage based on those scores, so do some process mapping so that the providers can really see value in what we're doing, not just use a tool, but how is it actually what purposes is it actually serving? We want to look at the patient experience. So currently we use the OPOC, so we are constantly looking at and getting feedback from our patient pool. And I think the big piece when we think about engaging providers is the ease of use for them and the value that can be seen in the change. So. And I think all of us hope to move forward engaged in QI initiatives. I'm on a quality improvement committee, as is Bob. Sean is involved at Aurelia Soldiers, so we hope to continue to grow and live in the way of quality improvement as we've learned so much here. So thank you.
Thank you so much. And going first, too, right? Thank you, folks. Panelists, what are you curious about? Oh, now you're curious why my microphone suddenly came on. What are you curious about?
So thank you for that presentation. Very well presented and a really important area that reflects the standards. I'm curious about what you've learned from those providers who push back on this. What feedback did they give you that helped you to understand how to do this?
I did kind of a mini survey about a month into the pilot to see what the thought was around it. And some of the feedback was, I'm already using a tool. Why would I use a new tool? So one physician said for years in her practice, 20 plus years in practice, she'd been using a different type of tool. So that's why I think moving forward, showing the value of this specific tool. And we may not even, continue to focus just on one tool, but how can different assessment tools inform treatment and the most appropriate treatment for individuals. So that was one piece. The other piece was kind of the make work piece, right? I had stressed the importance of, for data collection purposes, we need to see the results in the EMR. And one physician said, that's more work for me. So we looked at what are the different options. So they can do it within their note. They can embed it within their note that they use the PHQ-9. They can actually complete the form. They can just do the tick box on the e-referral. So there was a number of options that we were able to identify. But I think that ease of use is something that we're going to have to continue to focus on for sure for the providers. Yeah. Does that?
Yeah, great. Okay. Thank you.
Thanks, Val. Great presentation.
Mike's my buddy from a while back.
Go way back.
Colleague. Yeah.
You mentioned the Ontario Perception of Care tool, and I was just wondering if the intention is to use that as a means to measure the client's experience now that this process is happening. Is that a better or worse or same experience for folks?
Yeah, because we're so early in the stage of it, it will be interesting to see what that looks like. But our program's been using that tool or a similar tool, survey, and you've done results for me in the past, ongoing. So the hope is that we can continue to get feedback, and that will inform kind of next steps. So hopefully.
Thanks, Val.
Yeah, thanks.
I have a comment as well.
Okay.
I thought your project did a great job of kind of highlighting how project scope can look very different.
Yeah.
Because on one hand, you're focusing on a very specific intervention about having people have completed PHQ-9 to triage. But despite that being just one small part, it is still a lot of work because you're doing with different agencies.
Exactly.
And I think that's an interesting thing, right? Like sometimes we think of scope as in all the interventions you're trying to do. And sometimes it's actually about all the partners you have to work with.
Absolutely. And we struggled with that early on, I think, right? Where we thought, this is too small, right? We started really big and we made it really small. And yet, that change is significant, we think. And we hope that we can continue to expand it and move forward.
Yeah, because I think because you focused on the smaller scope on the actual intervention, it actually allows you to get more done and do it in a way that you felt was more maybe meaningful or maybe more sustainable before kind of taking on multiple things that I can imagine from projects I've done gets like messy and harder to follow through with. So I thought that was a great highlight of that.
Thank you. Thank you.
Comments or questions from the group? We just have to ask you to use the microphone because the live cast can't hear us if we just talk. So any comments or questions from the group? Some of you are working on PHQ-9. What are you interested in? Can't change your slides now, so you just... Thank you, Lisa.
Who? Where? I might have missed this in your presentation, but I'm wondering what your volumes were for how many referrals overall versus how many would be appropriate for the PHQ-9?
I should have brought some notes in I have my own way of thinking around volumes, but if I were to think of the number of referrals on average that we get a month, we're looking at about 350 plus referrals, new referrals per month. The fact that they're coming to mental health counseling clinic, we, as a standard at our clinic, we use the PHQ-9 and GAD-7 at that first appointment. So we're just hoping that the PHQ-9 will be completed so that we can really look at risk, urgency, and determine what's the best fit for that individual. And when I think about that, I think about kind of a tiered approach to care. So we're looking at the next steps around developing program, it will be things like increasing self-management tools for the mild scores that come in, that kind of thing. And I actually did look at numbers of the scores coming in. So when you think about mild, moderate, severe, they're about 25% across the board as an average. So we want to just be able to make sure people are getting the service that they need when they need it and the most appropriate, because not everyone needs to come in and receive counseling or individual, right? So does that answer your question? Yeah, okay.
Excellent. Thank you, Valerie and Shauna and Bob. Thank you for going first. They get an extra cupcake. So as they're getting their photo done and they're presented with their certificates, the Christines, where are the Christines? Can we get the Christines to come up? Relapse prevention through implementation of health quality standard for depression. So we'll get you guys situated up there.
To the microphone. Yeah, okay. So good morning. So our presentation is around, we look at the most severe. So Valerie was just talking about people with mild depression. We were talking about people who have the most severe depression. So they end up in our inpatient 40-bed unit. And so that's where we focused our project. We were thinking about inpatient and outpatient, but we ended up focusing it on our inpatient. So we're going to start with a client story that I think personifies sort of the impact or the potential impact of what we did. So we focused on a lot of education, and one woman in particular, we'll just call JF, she's a middle-aged woman admitted to our inpatient unit with major depression, and she attended a lot of the groups that we had running on our PDSA cycles, and she began to realize during these groups that it was really important to her to stay socially connected in order to be well. And she said, she said, it's important for me to be well, but all I have is my cat. And she said that a couple of times, all I have is my cat. And she was a bit of an inadequate woman, and even though she was probably in her 50s, up until recently her mother had done all the sort of social structuring for her, and her mother had recently died. So she was able to take some of the insights from our depression groups and take them back to her treatment team and say, I think I need some ways to be talking to people when I leave here, not just my cat. So they actually translated that into making a number of referrals for her that made sense to her, that she was really on board for. So we found that kind of gratifying that we were able to be part of that process and really help her to gain some insight. And a couple of the groups that we used were the lifestyle comparison grid and the personal medicine that actually helped with that.
Okay, our lessons learned were our enablers. It's a new experience for patients to attend a diagnosis-specific group on the inpatient unit. We did have support from our director during challenging times with staffing. Staff are positive with our intervention, saying that there was structure and it really helped with their one-to-one interactions. We focused on patient learning, which reflects the recovery model. The challenges, we have a low number of patients on the unit with the diagnosis of MDD, approximately 20% at any given time. And also the challenge was having closed groups on a large unit was difficult, as other patients also wanted to attend the group therapy. Our other challenge was outbreak. We had norovirus, we've had renovations, and staff challenges.
So just say about how the outbreak meant you couldn't run groups.
Oh, right. During the norovirus, there were no groups that we could run at that time. So what we were trying to accomplish, our project aim statement was by April 2018, all adults who have an admission for MDD will be offered consistent education and information on major depression. Our outcome measure is the percentage of patients with MDD that receive standard education prior to discharge, and our key process measures were documented education by group or individual teachback. The topics included medication management, relapse prevention, crisis planning, and goals and coping strategies. So there was a variety.
So our changes ended up focusing on both of these two things. We've mostly talked about the groups so far, but we did groups and we did a toolkit for one-to-one education. So some of the groups that we ran included the lifestyle comparison grid, which was really about what does some of the things that somebody who's mentally well do versus somebody, sort of habits that somebody might do who's depressed. And that really was very, very successful. Personal medicine was really what kind of things work for me, not just medication, but what kind of things do I find really are helpful for myself, and a lot of discussion around that. Also looked at medication. That one we decided maybe wasn't that best in group, but nutrition and sleep were a couple of other topics that we've tried so far. We need to try some more that were quite successful. The toolkit that we've been developing included things on creating your own crisis plan, signs and symptoms of depression, medication, which we found worked quite successfully on the one-to-one basis. We had our pharmacy student develop a education page on that, and coping strategies. And what we did was we created a visual of a toolbox, and then we had pages for each of these things, and we did PDSA cycles on sort of what each of these different things would have on the page, and we got a lot of really positive feedback from patients and staff around that so far. Learnings, I think like everybody else, started way too big and have learned to go narrower and more deeply. So I think I've talked actually about our PDSA cycles already. I was doing this one, right? Yeah, okay. So we're going to show you both P charts and I charts. So starting with the P charts, and I don't know if you can see them, but this one is for the groups, and the bottom one is for the one-to-one, so we've got them separate. And you can see that in both cases we've ended up with going from almost nothing to having quite consistent education for all of our patients, and that was our goal.
We also ran a balancing measures with the eye chart, and also it revealed that each patient that was admitted with MDD attended or had the intervention of group or education one-to-one was approximately 2.5%. So the qualitative results, the impact of our results so far, the clinical outcomes, all patients who desire education about MDD are receiving consistent teaching. Patient experience, sharing relevant experiences about depression was helpful. I liked all the teaching and material that I received. And the staff experience was I had the time to do this instead of just talking with the patient. I liked it because it gave us structure to talk through. And the next steps to progress improvement. Go ahead.
Is that mine?
Yes.
Okay, good. So there's an example of one of our group sheets there, the lifestyle comparison grid. So further PDSA cycles that we hope to do, we would really like to expand and refine the group topics and some of the materials that we're using. And we had the chance to take a couple of staff to the groups and use it as an opportunity to teach them, but we'd really like to create a more structured approach to that so they could be doing it and then sustain that better. And we're still working on what the clinical workflow would look like for the individual teaching, where we would keep the materials, how we would make sure that we would know what's done. Although it is in the EMR now, and that's very helpful. Also, we have plans to get some tablets and implement a sustainable system for getting consistent patient feedback on of this. Future steps, we're really hoping to scale up to do major depression education to include our outpatients. We're looking at a group there, and to network to our partners. We're now the Toronto East Health Network, so we want to be able to include some of our network partners in that. To expand what's working on inpatients to include other diagnoses. One of our staff's comments really was, well, this is great, but this is only 20% of our patients, so what about the people with schizoaffective disorder or bipolar or schizophrenia? So we would like to have similar opportunities for them. And then great idea from one of our sponsors to create potential research to expand across transitions. So not just even within our own network, but transitioning before and after the hospital. And I think that's it. Yes. Yeah.
Excellent.
Thank you. So we were there.
Thank you. And this group reminded me, to thank all of you for posting all of these great tools and toolkits that you're creating to Quorum, because we can all share in it, right? And I think many of you have gone in there and bumped around and looked at what other teams have been creating. There's no point reinventing the wheel. So thank you for posting and sharing your work in that manner. Panel, what are you curious about? Go ahead, Paul.
Just wanted to follow up on the point you said that there's low percentage of people with depression, and then you talk about some of the people said, oh, we should expand it. And I wonder, for a lot of people, regardless of the diagnosis, having difficulties with mood or stress, if there's parts that are kind of translatable, so to be open to more groups, obviously, who are able to kind of tolerate a group setting, and then you focus the individual maybe on some more specific things, like you mentioned medication, or other ones. It sounds like you get a lot of people in that sense, because a lot of people might not describe having depression, but they describe still having stressors, or still might do really well with relapse prevention, or thinking about what are some social activities to structure your time when you leave. It sounds like these are all great ideas you were covering in it.
So we actually did do some, because we had some staffing challenges and some of the people that normally would run regular groups were off. We focused on depression groups, but we ended up looking for ways, so like nutrition and sleep and stuff that could incorporate some of those people as well. With the medication, when we ended up deciding it was better with one-to-one, I think we'll need new sheets that are for different types of medication, not just antidepressants. But yes, absolutely. I think a lot of it's expandable.
Yeah. Ross, go ahead.
So thanks for a great presentation. So I wanted to dig down on the staffing challenges and how you dealt with that. That's real life, right? So it's an important component of this. How do we integrate the improvement work despite the fact that there are often things happening that we can't control?
Well, there were staffing challenges. We had one of our workers, social workers, that had to be replaced by another social worker after they slipped and fell at the TTC and ended up with surgery, etc. So, I mean, that's just one specific case, but we've had, there's been other changes. So it's hard to pinpoint, but I think staffing challenges are, they're always there.
Yeah.
I guess we had to adapt. We had a lot of support from our sponsor who said, don't try to take on the world, just keep going with your project. And if you have to help out, then find a way to help out and do your project at the same time. So that's what we ended up doing.
First of all, I really appreciated your opening with the client story. I think that really brings it alive, I think, and it was very helpful. I was curious about the standard education and what that looked like and to make it standard.
So what it looked like is our PDSAs were trying different tools, and sort of tweaking them. But we had a picture of, well, first of all, what it looked like is we trained all the staff about what this was going to look like. We used the Teach Back method as sort of best practices, and then we trained them in Teach Back, and we trained them in what our process was going to look like. And so then our process looked like a picture of a toolkit, and then some of the tools were like, so this one's on community resources, this one's on relapse, or not relapse prevention, but signs and symptoms, this one's on coping strategies. And so they could visually see, and then each patient with depression got that picture, and then they got a chance to kind of work with the staff around, I would like to have more talks about this or about that strategy. And then we had some handouts to help run through the conversations on each of those. And so far, the feedback from the patients has been very positive, that they've been liking that. So that's the basic way it looked.
Thank you.
Yeah.
We have time for one quick comment or question from the group. Anybody curious? Because none of you have had staff turnover or any sort of organizational challenges, so.
So I just wanted to, my name's Linda Young, and I'm actually their director. And we've been meeting regularly throughout this process. But I would say it really, I want to emphasize that concept of adaptation, because we had one thing after another, and we just, part of the PDSA cycles and their conversation with me was, you know, how do we make this continue to fit? How do we turn lemons into lemonade? And it's like we just taking, make sure you have enough pause and other people supporting you so that you can look from outside and see something you can't see, to keep the things fitting. Because as Ross has said, this is like an outbreak, closure of our 5-bed secure zone, required renovations for safety, and you know, workplace violence challenges, sick time from staff, and actually incidents all happened at the same time through this process. And I'm extremely proud of the work that they've done. They clearly have done a number of PDSA cycles. They engage staff and patients. Like throughout this, I don't think you talked as much about the patients you used to actually test things, that they were partners in designing the tools and then partners in using and giving feedback. So we have a really great foundation for a program going forward. And I really also, we talked a bit about the transferability. I would encourage everyone here to think about the transferability of anything you've done with depression to the other two major packets of standards that we have for mental health. Because I do think there is transferability, and I think you can take way more than you've created back to your organizations to get other people involved in standards use.
Excellent. Thank you for your comments, and thank you for your leadership support. I really appreciate it. Thank you very much. Congratulations. 2 cupcakes for you. Yeah, we should have mentioned that. Any of you who have leaders here in the room with you, they're welcome to be part of your photo. Absolutely. Timmins folks. Deborah, Tanya, Bosa, and Kelly. And I suspect Natalie's listening in, is she? Should I say hi to Natalie? Depression Quality Standards Project Transitions in Care.
Is this on? Just test it here to see if it works. Alrighty. Good morning, everyone. I just want to test to see, I speak fairly low, but I sound loud right now. Is that okay with everyone? Okay, let's get this show on the road. So we are doing the Transitions in Care project. With me today, we have Tanya from the Timmins Family Health Team. We have Bosa from the Timmins District Hospital. We have Kelly from CMHA, and I'm Deb from CMHA as well, and project lead. And missing in our photo, we have a person with lived experience, Bonnie, and we also have Julie, who's the inpatient social worker. Wasn't available for the photo. So, our patient story, this is not typical, but it's something that could happen. Patients admitted to MHU with major depressive disorder, has several issues, including a suicide attempt, spends maybe a month or so trying to find a medication that's effective and that he can tolerate. He's put on a Form 1 due to suicide attempt, and then a Form 3 due to continued suicidal ideation. Upon feeling better, is discharged, and a referral is sent to CMHA. He's advised to follow up with CMHA, but he doesn't follow through. When CMHA worker is finally able to reach him, he says he's not even aware of the referral and not even sure that he needs services. So this is what prompted us to talk about and look at how we can better coordinate our services. So, what has been helpful for us? Can't say enough about our coach, Alice. She's been at every meeting, visited us a couple of times, and thank you very much, Alice. Without you, I don't know where we would be, but thanks again. Just attending our weekly meetings, having a resource person to lead the project, I think was helpful, and having a psychiatrist on board as well. Input from all of our respective organizations. This project enabled us to network and create links to resources, which we found was important as well, and having the key members on the project team. We spent a lot of time on root cause, which helped us to narrow down our project aim. I think I heard a few other people in their presentations prior to this say they've changed it up I don't know how many times, and that was the case for us as well. So, and then we finally had to get going, being that it was a 6-month project. So, challenges, you guys aren't aware, but because it's not on the slide here, but one of the challenges, I think, finding people to present. All of a sudden, everybody developed an anxiety disorder. Every one of them. True story, you know, and including the psychiatrist, yes. So, data collection was an issue for us at first. There was very little turnover in the unit. It was full, and just people weren't coming in. There was a wait list. Creating a care plan that would work for all of us, different mandates and so on, and we had differences of opinions. I don't know how many times we changed that care plan, which you're going to see later on, which I should speed up so we can spend more time on that. The scheduling of weekly meeting was really difficult because of, again, with the 3 organizations. Completing charts with the minimal data was difficult. Initially, we thought we had data quality issues with the RAI not being coded properly, but found out that wasn't the case, and you'll see that in the run chart later. It was actually accurate, it's just the numbers were low. And the other challenge that we see, and that's more in the future, is that the sustainability may be an issue just due to the lack of resources. I won't be able to be lead forever, so this, we'll have to plan that out. Sorry about that. Oh, somebody should have yelled at me. Okay. So anyway, I thought we were changes we were testing. Okay, yeah. I just want to see this. No, the changes we were testing. I don't know where that is. Seem to be missing a slide. Anyways, our project aim statement: 100% of adults with major depressive disorder who are discharged from the Timmins District Hospital (MHU) will have a plan for their care, which includes a coordination of services. So our overall hope is to decrease recidivism rates, reduce hospital admissions, and provide appropriate follow-up care in a timely manner. How we want to accomplish this, we have devised a tool that I spoke about earlier, coordinated care plan. And what we also did was created a cheat sheet so that staff and patients could both use in order to help them to fill it out. And so that to ensure that we had consistency, everybody would fill it out the same way. This is our coordinated care plan. I guess, oh, you can see it better up there then. That's good. So you can see the first part is just our demographic information. And then we have just the 3 organizations, who the patient's being referred to, just for the purpose of this project. So just the Timmins Family Health Team, CMHA, or the hospital. And the second part is very brief. It's just the inpatient summary, just so that we know who to contact, who to get together when we're trying to coordinate the care and the plan, and so on. And then the mental health status at discharge. We have the patient's perception and the psychiatrist's perception. I'm going to talk about that a little bit later on as well, because there was, when I was gathering data and getting feedback, there was some talk about the patient's perception maybe should be down in with the patient's follow-up piece. But we had other feedback to say, no, we really should leave it there so that we could see the contrast or the differences, and then it would leave, that time for discussion or dialogue or whatever. And as you can see, the bulk of this plan, and purposely so, is actually for the patient, and it's their follow-up care plan. So we want to hear from them. What do they feel that their challenges are, their strengths, their goals, there's the summary of a safety plan, who they have as ongoing supports, and that kind of thing, and any medical appointments, psychiatric appointments, or social counseling that they would have after. They take this plan with them. Whoever they're being referred to gets a copy of this plan. We have something in place where somebody from the hospital will be outreaching to people who are discharged to see, did they get a copy of this plan? Are they having any issues with it, that kind of thing. Really important to note that this really is the client's plan, and we're just there to assist them. Changes, we are in the process of testing, and that's what I was looking for earlier, so I'm glad we didn't lose it. So the number of patients that we being discharged from the mental health unit diagnosed with MDD, and then after that we plan to collect the data on those with a major depressive disorder who actually fill and receive the plan. We collected feedback from patient, staff, managers, people from the Patients Experience Advisory Committee regarding the use of the ease of use and the understanding of the plan. So I've gathered some data there. And we've made several changes to the plan, as I said earlier, and prior to testing with the patients. And we really think that it'll be a good tool in ensuring that patients get timely access to services. The results of the interviews that I held with patients in the mental health unit, the direct service staff and managers, included that, oh my God, some felt that patient's perception and psychiatrist's perception should be separated, and others felt it would be more useful to keep as is. Some didn't feel the word perception was appropriate, so I'm still gathering feedback on that, and if that's a general consensus, we will change that. Everyone felt the plan was easy to follow and understand, and patients who were interviewed believed that using this plan would increase their chances of receiving follow-up care quickly, or more quickly. And here's our run chart, and as you can see, the numbers are, we probably have an approximate four individuals maybe in a month that come in with that diagnosis. And next steps, continue to meet with our organizations. We don't know yet. Stop. Stop. Hey. I did this in 8.5 minutes last night.
We did have a PDSA on timing. So. Thank you for your kind words. My kids call it nagging, so I'm going to show them that slide where it's called coaching. It's not called nagging. What are you curious about, panel? Go ahead, Michael.
Great project, Deb and team. One question I was wondering is if you ran into any challenges or barriers regarding communication of information, from hospital to community and that sharing. I know there's been other teams that EQIP's worked with where that's been a bit of a barrier. The concerns around privacy and things like that. I wonder if that was an experience you had at all.
Absolutely. It's been an ongoing challenge, actually, and even when I did interview patients at the MHU, what I promised to do is just not take any. I didn't use names. In fact, I didn't even use names of staff or managers or anybody else anyway. I just kept it the same across the board. But it is a challenge, and I'm not. We're still trying to work on how to get around that. We had the Julie, she works in the inpatient social worker, and she can get everybody to sign, consent forms, but she's rather busy too, so that poses a little bit of a problem. So, and I did wonder whether that was covered under the project, because we did say if it was, is for statistical purposes in the project, that confidentiality, there were different implications. So, but we were playing it safe. It's a good question.
Sorry, just 1 minute. Yeah. I think it's important as well to say that our medical advisory council has actually bought into the project, and so the coordination among the three teams, the CMHA teaming and the family health team has improved significantly, and the doctors are all on board. And again, the major problem that we have will be resource-wise, right? Thank you.
Thank you. Yeah, Ross, go ahead.
So thanks for this project, because care transitions are a critical issue here, and making sure that people are followed consistently. I wonder if you could say a little bit about any challenges you faced in developing that tool, because it looks great up there, but was it a tortuous path, and if so, how did you manage that?
Well, I have to say, honestly, we have a good working group, and we're very respectful of one another. And I think when changes were brought forward, they always made sense. They always made sense to me anyway. And we just continued to tweak and continued to tweak. And we always just seemed to feel better the more that we tweaked it. And then, like I said, when I did the interviews, I wasn't getting very much in terms of any negative feedback or even anything that we could improve, except for, like I say, that one section about they don't like that word perception, and then where it's located. Yeah. Good question.
And kind of following up on Ross's comment about thinking also earlier you said about reducing workload. I wonder, so it sounds like people have found this helpful, and it's a tool that patients can take with them, which is nice, right? Because often sometimes it's verbally communicated and written. Ways of integrating into some of the workflow that's already there. So I'm likely they would have to do a discharge summary. Is there a way of saying with the staff there about, is there a way of incorporating into discharge summary? Maybe it's reducing the amount of workload for the discharge summary because it's going to be part of the care plan. A big part of transitions often is communicating it to either the family doctor or the community teams they're going to in a timely way. And if it's simplified, and if you're already doing such great work, because probably at the end, what people care about are follow-up plans, right? Like if you go to a medical hospital, you go in for a heart problem, the family doctor's probably looking at, okay, what do I need to do? Like what medications, what appointments are there? The stuff that you're working on.
Yeah, and
I wonder if there's opportunities for that.
I'm really glad that you brought that up, because I did not get time to say that in this slide. So thanks, Alice, for because that was actually my last point. One of our really important next steps is to determine what that process is. We threw out ideas in terms of meeting the patient. Always, to me, nothing without us, nothing about us without us is our motto, kind of thing. So the patient has to be there, but we also want whoever they're being referred to there, as well as who's ever the referral sources, and hopefully the doctor as well, but whatever we can do, so we have that discharge meeting planning all at the same time before that person leaves hospital, so that we can coordinate this. So again, that's a process that this is where we are in the project right now, unfortunately, because it has been difficult with when you're just one organization, like on the EKIP project, I found it a little bit quicker because you're just dealing with people within, but that's where we're at. We now have to develop a process on how we're going to make that work.
Just sorry, I know, hogging a bit of time, but just it might be like a step process when you think of scope, where you have like, this is how we'd like to see it in the end. That might be your driver's diagram. But like a small part might be just like fixing out, well, what would this look like just on the inpatient when we discharge, and what would the process. And then when you feel comfortable, another project could be, working better with, community partners to see how that's communicated. Like that might be one way of managing the scope, because I can imagine, it could be like, oh my God, there's so many partners we're working with.
Yeah.
But it kind of works out really nicely the way you've laid it out.
Right.
Thanks.
Thank you.
And we'll have one more question. I just want to introduce Lee Fairclough from Health Quality Ontario.
Oh, hi. Sorry. Great presentation, and really enjoyed hearing about your experience. As you continue, there's an interesting project, and I wonder if you drew on it, called the Patient-Oriented Discharge Summaries Project, that's being implemented and spread in Ontario currently. I know that there's been a few groups that provide mental health care that have been involved, and the comment about how you integrate it into processes and workflow kind of triggered my comment, because you said that's going to be one of your next steps. I think that there might be something to learn from those other teams that have done it, and we can facilitate connecting you with them just to kind of learn about that.
Absolutely. That would be great. Awesome. Thank you.
Excellent, thank you. And so as these folks move to get their certificates and their photo, we'll move to break. No cupcakes yet, don't get excited. No sugar high till lunchtime. But we will come back right at 10:30 so that we can respect our live cast times as well. So thanks to the three teams that took us through the morning, and we look forward to more.